the outset, let me thank the organizers for having given me this opportunity to speak to you today. And I will now go ahead with the topic that's been given to me, which is approach to chronic conjunctivitis. I think the number of conditions that fall under chronic conjunctivitis is very huge. And I have tried to do as much justice as I can to the topic with the help of case illustrations. I think I'll start by defining chronic conjunctivitis, which is generally accepted as conjunctivitis that has been present for greater than 3 weeks. And when a patient presents to you with a picture that is suggestive of chronic conjunctivitis that's been there for around that period of time, and you've ruled out the other causes such as scleritis and uveitis, you know that what you're dealing with is a chronic conjunctivitis. The further scope of the talk is basically evolved around chronic conjunctivitis, and I would focus on an algorithmic approach to these cases with a very brief overview of the disease and management plan with the help of case illustrations. I think the most pertinent questions that I would like to ask myself when I see a patient of chronic conjunctivitis is the laterality. Is this unilateral or is this bilateral? Is there a specific predilection for any particular lid in terms of affecting the upper or the lower lid, or is it just generalized? With respect to symptoms, probably the one characteristic symptom that I am significantly interested in is itching, because that tells me whether we're dealing with something which is allergic in nature or not. And the most important aspect of examination is to look at the morphology of the conjunctivitis, and I will be focusing initially on the bilateral cases of chronic conjunctivitis. So as far as morphology is concerned, I've divided it into these 5 forms: papillary, giant papillary, follicular, membranous, and cicatrizing. And under each of these, I've tried to narrow down the differentials based on the various conditions that we routinely see. So let's look at these one by one. Let's start with the papillary conjunctivitis. One of the most important causes that leads to papillary conjunctivitis is a moderate to severe dry eye. And talking about dry eye and the manifestations and the disease is probably out of the scope of this particular talk, and I will focus on the various other entities that I have mentioned here. So let's start with superior limbic keratoconjunctivitis. This is a very classic presentation where they present with inflammation below the upper lid, and the upper tarsal conjunctiva is significantly inflamed. You have papillary changes there, and the staining that you see in SLKC is significantly present. You can do a rose Bengal staining and actually stain the area which is inflamed. This is the same patient 3 months later after a very short course of topical steroids, copious lubrication, and the patient is also on topical cyclosporine. You can also have significant conjunctivochalasis. Usually SLKC is associated with both inflammation and chalasis, which is something that you appreciate when you push the lid down. You can actually see the fold of conjunctiva just beneath the upper lid, which is indicative of the presence of chalasis along with the inflammation. And this was one particular patient where we decided to go ahead with an excision of the chalasis because he was extremely symptomatic, and you can actually see the tenting of the conjunctiva when you lift it up with the forceps, which indicates the extent of looseness of the tissue which needs to be excised. And this patient underwent an excision of the excess of conjunctival tissue along with amniotic membrane. And this is the same eye 5 years post-operatively where he's absolutely asymptomatic. And since he started developing similar symptoms in the other eye, he was keen for surgery in the other eye, which he is awaiting. So in general, for SLKC, we adopt a stepwise approach. As I mentioned, we have done very few surgical excisions for the chalatic aspect of either SLKC or chalasis by itself. Apart from the modalities that I mentioned, punctal occlusion of the superior punctum is something that can help the symptoms in these patients by improving the tear lake in the superior cul-de-sac. We use large diameter bandage contact lenses to prevent the rubbing of the upper lid on the superior bulbar conjunctiva. And the last option is surgical excision. In patients with SLKC, we also look for an associated thyroid disorder. The other interesting situation that is associated with papillary conjunctivitis is floppy eyelid syndrome. And as you can see here, the lid easily flips and everts, especially superotemporally. This was a middle-aged, mildly obese gentleman who had been treated elsewhere for almost more than a year with this recurrent episodes of redness that he had. And when you take a history and you probe a little more, it does give you a history of sleeping prone, which is very characteristic in these patients because that's when the eyelid tends to just flip open and there's direct rubbing of the ocular surface on the surface over which they are sleeping. And this is the same eye 1 month later. I've used topical steroids for just a week, but what we did was used a rigid protective shield at bedtime, and just with the use of that, there's a significant amount of improvement in the redness along with the use of lubricants. So this is a situation where you need to ask for the appropriate history, and these are patients who also have a strong association with obstructive sleep apnea. And patching or shielding is the treatment for these patients along with copious lubrication at bedtime, and a permanent surgical approach would be to consider tightening of the upper eyelid by the oculoplasty colleagues. This was an interesting situation, a young child who presented with chronic redness. She had papillary form of chronic conjunctivitis. Since 1 year, she was on and off on topical steroids. But if you look closely at the eyelashes, she's got blepharitis with a very classical, what we call as a cylindrical dandruff, and which is characteristic of Demodex. This is another patient who also had a similar picture with a marginal keratitis like episodes that she kept having repeatedly. And when we removed the lashes to check, both these patients had the presence of the mites, the Demodex folliculorum in the lashes, which following treatment significantly brought down the inflammation in their eyes. And treatment that we follow is primarily topical, where we use the tea tree oil treatment either in the clinic or at home, and advise them to keep the lashes clean with regular follow-ups. Moving on to a giant papillary variant of chronic conjunctivitis. The most common cause of conjunctivitis that causes the giant papillary variant is vernal keratoconjunctivitis, or AKC. And apart from that, you can also have contact lens prosthesis or suture-related GPC. So this is a very classical PKC where you have the giant papillae in the upper eyelid, which ends up causing shield ulcers. And in this particular patient, she also had an associated skin allergy for which the dermatologist treated her simultaneously for the skin problem also. The management of VKC and AKC is out of the scope of this talk, but this is the most common disease that causes GPC, and this is the disease where the symptom of itching gives you is of diagnostic value to tell you that you're dealing with an allergic condition. There are certain instances in patients with VKC who have very large exuberant papillae, what we refer to as refractory GPC in VKC. This was one such child where since she did not respond to any of the routine management modalities for VKC that I just highlighted in the previous slide, we actually went ahead and excised the lesions and replaced it with a mucous membrane grafting. And this is the same eye following the procedure. So this is the child that had the mucous membrane grafting, and this is the post-op appearance, the external picture of the eye. This was another interesting elderly male with a chronic red eye, and this actually happened to be a patient who used to wear contact lenses, and I think the last that he wore it was daily disposable contact lenses, and he wore it more than a month back when he had gone to watch a cricket match. He thought he removed the lenses in both the eyes, but apparently he didn't. He had seen a few ophthalmologists, but when he came to me, he had this redness which had been persistent for more than a month. And you can actually see the rim of the contact lens when you look closely, and you can see the contact lens actually sitting in the eye. He had a small stromal infiltrate which had begun to occur because of the lens. And then once we removed it and treated him, eye cleared completely. So some of these instances are just out of the box kind of situations. You just have to examine closely, and for some of these foreign bodies which might be just left in the ocular surface.